So I'm Dr. Raney, and we're here today to talk about what's basically a small hole in your heart. And it's called a patent foramen ovale, or PFO is what we usually refer to them as. When we look at the heart, there is a small hole, and this is present in everybody before you are born. So when you're living inside mom, you're not exactly breathing very much air. As soon as baby comes out, you take a deep breath, and there's a little flap here. Most patients, it will fuse and get rid of this little hole. However, we know that about 30 or 40% of all patients, all people walking around, have a PFO. There's some sort of a tiny little communication there. These can range from very small to some get quite a bit larger. The problem that we see with PFO, and the reason that certain patients might need to have them closed, is that it can lead to a stroke. And basically, there can be blood clots that form in your legs. We know this is common when people get off long plane flights and they've done ultrasounds. They have seen that there's a large number of people will have little clots in their veins. Now, most of the time that will get pumped up to the lungs, get filtered out. The lungs are a very good filter for these tiny little clots, and it doesn't really cause too much damage. Now, occasionally though, if the circumstances are right, maybe a patient's taking a deep breath, it's possible that one of those clots could cross over here and then go to the other side of the heart, skipping the lungs. And when that happens, this could be pumped up to the brain, leading to a stroke. So in your case, you had the stroke, they saw it on an MRI. Fortunately, you've made a good recovery. But I talked to your neurologist and he recommends that we close this hole. Always something I like to do is to work with the neurologist to make sure that the hole should be closed, because these are so common, we don't close them for everybody. And for the most part, if a neurologist can't find any other good reason why you had a stroke, there's no atherosclerosis in the neck or other reasons that you would have had a stroke, then we think about closing the PFO.
I'm really nervous about this procedure. Can you tell me about it?
Absolutely. So let me show you an animation which I think really kind of helps to put your mind at ease.
Okay.
So basically, we know that little blood clots occur in the veins, and they usually get pumped up to the lungs and filtered out. But occasionally there's patients who have this small hole, and if one of these blood clots should find its way through that hole, it can then get pumped all the way across from the other side and up to the brain, leading to a stroke. And so this is what we do during the procedure. You can see we take a little tube and we go right through the hole itself. We get this in through the vein, the femoral vein, which is right above your hip, and sort of out to the side. And we use that to get back up to the heart, sort of like a freeway to get back up. And so we'll take this through here, we cross over, and then we take out this device. And basically it's sort of like a sandwich where you put one disc on one side, then we'll pull it kind of snug against the hole, and then we form another disc on the other side. And then once we're happy and we've assessed it, then we just release it. And then over time, the next 45 days, you'll see this starts to show it here, there will be a skin layer that grows in around this. And then if there were ever to be another situation where there was a clot or something, it would not get crossed over to the other side of the heart that pumps to the brain and would be filtered out in the lungs.
I just want to know if it's permanent or do you need to replace this?
No, once this is in, the hole's pretty much gone. I don't need to check on it again. So it will become part of the heart. And the skin grows in all around this, and it's called endothelial layer, which is basically just like a skin that grows and becomes part of your heart, and the hole will be gone.
How long has this PFO been around?
It's a good question. It's been around for a long time. We have other holes in the heart that are kind of in the same area that are bigger. So they came up with these devices to close them so patients didn't have to have surgery. We recently had 3 big trials in the New England Journal of Medicine that did show benefit to closing these holes in a certain set of patients. Again, it's not for everybody, and we'll work with a neurologist to figure out exactly who is a good candidate for this.
How do I prepare for this, Dr. Raney?
So when we do these procedures, we like to get a good look at the anatomy first, okay? The only way that I can really see this is through what's called a transesophageal echocardiogram. It's a big word, I know. But basically what we do is we have an ultrasound probe that's about this size, and it actually goes down the esophagus where your food goes. Turns out the esophagus is right next to the heart. So when we put this down, we can get crystal clear views of exactly what's happening in this area. Again, some of these can be really small, sometimes they're really big, and every patient is different. So before we do the closure, I'll want to see what the anatomy looks like, just to make sure. This is the device. It's made out of a material called nickel titanium. Nitinol was originally designed for spacecraft back in the 70s, but we use it in a lot of medical devices because it will keep its form. So if I let go, it'll go right back down. There's two different companies that we use that make them. This one happens to be from Gore, and you can see that there's two discs. And this will show you, there's one on each side, and basically what we do is we create the sandwich with these discs. So the hole would be in the middle there. The main goal here is to encourage, this endothelial layer or skin to kind of grow in around the device after it's placed. So that's what it's looked like.
And all different sizes, depending.
Yeah, we have all different sizes depending on how, well, there's two main sizes that we use, depending on how big the hole is. Yeah, once we put it in, it becomes part of the body. Skin just grows around and it's there. It's an outpatient procedure, but you can go home the same day. And we do them at the hospital because that's where we have all the equipment. We have a great team there. The people who scrub in with me, the techs, we have a cardiac anesthesiologist there. I'll typically do a transesophageal echo during the procedure to get really good images. And for that, I'll have one of my partners who specializes in getting the echo images. So the recovery from this is pretty easy. Patients will come in, we'll do the procedure, takes anywhere from half hour, 45 minutes. Afterwards, they'll go to recovery room, and there's a small little incision there. So it shouldn't cause any pain. Patients will then be able to be discharged, walk out of the hospital about 4 or 5 hours later, and they really don't tend to need pain medications. They should feel pretty good. I tell patients to take it easy for about a week, just in terms of heavy lifting or doing really heavy exercise. But for most patients, they can go back and do everything they were doing before they came in. All the patients who come out say they had a terrific experience, working with the team at St. Joseph Hospital.
Why am I going to you with this? My
Yeah.
neurologist recommended you. Why? Tell me about your experience a little, Dr. Raney.
So I've had a lot of experience. I've been doing this procedure since my training down at Scripps, which was about 10 years ago. We do a large volume both at St. Joseph and at St. Jude Hospital. I do this procedure at both places. And so I think with doing a lot of procedures and getting more experience, I think we get better outcomes. Basically, this should be about 100% success rate, okay? The only times where it's not successful is if I bring a patient in and we think we saw a hole, and then we go in there and there's really no hole. And so sometimes we'll put up a wire and make sure that there's nothing there. But basically, if there's a hole, it should be closed with 100% success.
Why is Providence such a great place for having this done?
Both St. Jude, St. Joe's hospitals are just excellent in terms of the staff and everybody who works there, nurses, everywhere from the nurses, the people who scrub in, to the other physicians. When you walk in there, there's a really good vibe. It's unlike other hospitals. And so it's a really good place to work, and I think that kind of gives us more success.